Hi, my name is Lauren Tucker, and I'm a hospice nurse with a great passion for this area of medicine. I recently transitioned to home hospice after working in critical care for 8 years. The more I worked in an ICU setting, the more I appreciated a dignified death. I've witnessed countless patients take part in traumatic hospital stays, resulting in prolonged deaths. When we exhaust all efforts to treat a patient, we often rob them of a graceful and peaceful death. This thought weighed on me for years, but the COVID-19 pandemic intensified it. Watching patients suffer for months, some dying without any family by their side, was one of the greatest challenges I have faced in my career. My passion for hospice and palliative medicine began to foster in light of these heart-wrenching moments. After several months working in hospice, I recognized barriers within the specialty. One that I'm particularly invested in is properly assessing level of discomfort and pain in patients at the end of life, especially when they're unresponsive. Which brings me to my EBP Proposal project, assessing the reliability of the Edmonton Symptom Assessment System, or ESAS, in various patient populations at the end of life. The first topic I want to discuss in the background is what are the symptoms at the end of life that we are particularly concerned about. Pain is arguably the most common symptom people associate with end of life and dying, but it is only one of the many discomforts people experience, while some may never experience pain at all. The most common end of life symptoms aside from pain include dyspnea, nausea, delirium or agitation, constipation, oropharyngeal secretions, fever, and decreased consciousness or lethargy. Hospice and palliative care focuses on treating these symptoms before they start with multiple pharmaceutical and non-pharmaceutical interventions. Some of these symptoms are more likely to be seen during the active phase of dying. So what is the ESAS? The ESAS is an instrument that assesses symptom burden at the end of life. Ideally, the assessment is completed by the patient, but may also be done by clinicians or caregivers. Symptoms are measured by a numerical rating system from 0 to 10. The ESAS Revised, or ESAS-R, is more commonly used now and assesses level of pain, tiredness, nausea, drowsiness, dyspnea, appetite, well-being, depression, anxiety, and other. Today, the ESAS and ESAS-R are used interchangeably, and for the purpose of consistency, I will be referring to the ESAS-R as ESAS. The ESAS was developed by Dr. Eduardo Barrera and colleagues in 1993, so it's fairly new. Dr. Barrera practices palliative and integrative medicine at the University of Texas Cancer Center. The ESAS is widely used in the palliative and hospice specialties around the world. It has been validated in multiple languages and permutations. In fact, there are so many permutations of the ESAS that it is safe to assume most palliative or hospice providers develop their own version with respect to the core foci described in the previous slide. Several strengths and weaknesses of the ESAS were identified in my literature review. It was shown to provide adequate evaluation of pain severity and may even reduce adverse effects and hospitalizations. It was also shown to inadequately evaluate psychosocial symptoms and may not be user-friendly to patients or clinicians. All that being said, my purpose statement for this proposal is: the purpose of this project is to assess the reliability of the ESAS in patient populations with various terminal illnesses. The chief research gap of interest is that most of the literature has validated the ESAS with studies involving patients with cancer. So why is this a gap? Hospice has long been associated with terminal cancer, but there are numerous terminal diseases that warrant hospice care. Only 30% of all hospice recipients have cancer. Hospice patients with cancer receive the fewest days of care second to those with CKD. This is important because that means the ESAS is being utilized more and for longer on other patient populations. My research design is an interventional quantitative study. The primary research method is the use of the ESAS scale, but this may include observations and assessments of patients, interviews with families and caregivers, and physiological measurements such as vital signs in order to accurately complete the ESAS, especially on nonverbal patients. Through quota sampling, a sample of 80 hospice recipients will be recruited until there is equal representation of patients with cancer, Alzheimer's or other dementia, heart disease, respiratory illness, and other. The setting for this study will be the home of each patient, whether it be independent housing, assisted living, or a skilled nursing facility, wherever the patient is receiving hospice services. Data collection involves ESAS assessments conducted on paper by 4 different nurses within 1 hour. A total of 4 separate assessments will be done on separate days for each patient. Other data to be documented includes patient age, gender, community of residence, meaning urban, suburban, or rural, and primary hospice diagnosis. Patient demographics and diagnosis will be analyzed through descriptive statistics. Reliability of the ESAS will be assessed through Cronbach's alpha coefficient. And finally, the differences in ESAS assessments between clinicians will be analyzed through ANOVA. So how is this proposal significant to nursing? Well, compassionate care is arguably the foundation of all nursing practice, and it is the pinnacle of hospice and palliative medicine. Against the stigma, these patients and families open their hearts to the hospice philosophy. They deserve the utmost compassionate care fueled by the best evidence-based practice. And because many of them are concerned about end-of-life symptoms, the research should be focused on this. If we properly assess symptoms, we can properly treat and manage symptoms, which maximizes the quality of life for the remainder of these patients' lives, and this leads to better patient and family outcomes. From my literature review, usage of the ESAS is rarely challenged, likely because there is little to no competition. This is exactly what this project is doing, challenging the widespread usage of the ESAS. Could there possibly be a better instrument developed? In general, hospice literature poorly represents patients with various terminal illnesses. As previously discussed, it poorly reflects reliability of the ESAS on these patients. This project targets both of these issues. Implementations for practice and further research will be dependent on the results themselves. If the study shows reliability and consistency of the ESAS in various patient populations, then this supports the widespread usage of the ESAS on all palliative and hospice patients. If the study shows limited reliability and/or consistency, then this may indicate that further evaluation of the ESAS on specific populations is necessary. Clinical recommendations may be discussed, such as a nursing protocol to maximize all available resources. The goal in hospice, remember, is to manage all symptoms at home. In order to do that, nurses, families, and caregivers must have access to all interventions, whether they are needed or not. Psychosocial instruments such as the Hospital Anxiety and Depression Scale, or HADS, may also be utilized in addition to the ESAS in order to adequately evaluate psychosocial symptoms. Psychiatric consults may also be recommended in situations where patients express psychosocial symptoms and are seeking treatment. It is also important to utilize social work and a chaplain to examine all aspects of discomfort. There are 3 major reasons why my proposal should be funded. Firstly, hospice and palliative care are chronically underfunded specialties, and it has led to poor care in dying people. Second, death is not given enough focus in medicine or in general. There are 2 truths in life. All humans are born, and all humans die. As a society, we have no problem discussing birth because it is the symbol of a beginning. Death is often associated with fear and uncertainty, which only leads me to believe that we all need to be better prepared for it while we're living. Although death indicates an end to life in a particular body on this planet, it does not have to be absolute. It does not have to be scary. It does not have to be uncomfortable. Through hospice, death can be just as beautiful as birth is. Lastly, clinicians do not receive enough education on death, dying, and providing comfort. Research is needed in order to improve curriculums, training, and ultimately the way we practice.